Thank you, sir. As majority of us are doing pediatric cataracts, I think this talk is only for the people who are the learners. And I can assure you that management of pediatric capsules, I think once you've conquered that, things become very, very easy. I think pediatric cataract is all about managing the capsules. And I have no financial disclosures to make. And in all pediatric cataracts, I'll just give you a few tips that it is imperative to stain these capsules because one can delineate the capsule very nicely. And of course, when you're implanting the IOL, things become much easier. In viscoelastics, one has to use cohesive viscoelastics, and 1.4 sodium hyaluronate is one of the best. And a tip here is that when we are doing an anterior CCC, one has to keep the eye kind of hyperinflated because you want a flat anterior capsule. But when you deal with the posterior capsule, the misconception is that we should again have a very taut eyeball. But on the contrary, if you overinflate the bag, the posterior capsule falls back, and your rhexis, if you aim for 1 millimeter, will end up in 4 millimeters. So when you're doing a posterior rhexis, the bag should be kind of a bit deflated. So anterior rhexis inflated, when you're doing a posterior rhexis, a bit deflated. And various methods, first I'll do with the anterior CCC, and various methods. Of course, the most common is a manual one with initial puncture with the cystosome and then completing it with the utratas, and then the Clotis radio frequency, and some use the plasma blade as well. And one should aim at a rhexis of 3 millimeters to start with. And one will see as you gain experience that once you aim at 3 millimeters, gradually your rhexis will end up being 5 millimeters. But if you start with the preconceived idea of I'll make a 5 millimeter rhexis, as in adults, you'll end up in the periphery. Now this first video, as you've already seen, there is this stained capsule, and this is the utratas. The tip and trick here is to go centripetally inside and aim for this 3 millimeters. And this utrata forceps is all the time going centripetally, as well as it is lifting up the capsule. So it's not like in adults where you have a shearing horizontal force. And other thing is that, there are no egos here. You have to grasp and re-grasp as many times as possible, because in these pediatric patients you have to achieve a very, very central round 5 millimeter like you do for diffractive IOLs. Then now coming to the posterior rhexis, as I've already mentioned, don't hyperinflate. And the general consensus amongst pediatric cataract surgeons is the age group of 6 to 8 years. Up to 6 to 8 years, you have to do a PCC. Or maybe in patients who have nystagmus and difficulty in head holding with a lot of congenital disorders, you can increase this age group up to 10 years of age. And here, the posterior rhexis is definitely much easier than an anterior rhexis once you've done a lot of cases. But here we aim at a size of initial just about 1.5 to 2 millimeters, which finally achieves a size of 3.5. But this is the most crucial step, not only that you are taking out the posterior capsule, but because if your rhexis goes beyond 3.54, you can't implant a lens in the back. It's very, very risky, because once you have post-op inflammation and fibrosis, the lens will kind of tilt and maybe sink back. And again, 3 methods: the manual, which one could do with utratas or maybe use MVR forceps. Then vitrector can be used in learners after making the initial punch in the posterior capsule, and of course the Fugo blade. Now this is with the utratas. As I told you, this is the anterior rhexis you are seeing here. This is not very clear because this particular patient had a lot of Descemet folds and some kind of corneal dystrophy. And here you grasp and re-grasp, and this is always coming up. There is hardly any horizontal movement when you do a PCC. You just grab the capsule and kind of lift it up in just one central 1 millimeter. And there's some problem with my forceps as well here. And this rhexis, if it goes out, if it tends to go out, you should stop there and maybe fashion those edges with a vitrector if you want to implant the lens in the back. I will have the video to show. So can I just 30 seconds? Please. And then we do encounter these cases of posterior plaques with posterior lenticonus or maybe anterior hyaloid, which is more prominent. In these cases, life becomes much easier. See, once you've made a nick around the plaque, you can easily grab this and just shear it off from, because you have a nicely formed vitreous behind it. So capsular access in these cases is the easiest. You can just nudge it from all the sides after just making one nick and finally grab it and pull it out.
The talk is open for discussion.
And the last one, this instrument can be nicely used. Some people find it very difficult for a utratus to be put in because either you need very long blades of that. So the MBR forceps can be nicely used from either a side port or the main port to grab the indexes and make a 3 mm opening in the posterior capsule. Thank you.